Hello, am I audible?
Yes, Dr. Shrutika, you are audible.
Okay, sir.
Now you are host. You can make co-host to the other member and then you mute on the meeting.
Okay, sir.
डॉक्टर श्रुतिका झालंय कनेक्ट म्हटलं ना?
Yes, sir. Yes, sir. झालं.
ओके ओके. आता तुम्ही होस्ट आहात?
Yes, sir.
व्हेरी गुड. आता तुम्ही जर कोणी गडबड करत असेल तर म्यूट करू शकता. मॅडम जॉईन झालेत का?
मॅडम अजून तरी नाही झालं सर जॉईन. मी त्यांना टायमिंग दिलेला, त्यांना सांगितलेलं. एक कॉल करू का तरी?
हो हो मॅडम, तुम्ही जॉईन करू शकता का? आपण बघायचंय का स्क्रीन शेअरिंग वगैरे, किंवा
Okay.
हा मॅडमला जॉईन व्हायला सांगितलं चालेल आता?
ओके, चालेल सर.
चालेल चालेल. ओके. बस 2 मिनिट.
Good evening, ma'am.
Yes, good evening.
Ma'am, can you please share your PPT? We'll just check once.
Yes. Is it okay now?
Ma'am, your screen is not shared yet. We can't, the PPT is not visualized.
मॅडम ना co-host बनवा.
Is it
शेअर
is it seen now?
Yes, ma'am. Yes, ma'am. Yes, ma'am, it's visible.
Okay, then should I do like stop sharing?
Okay, ma'am, fine.
Dr. Shrutika, please start.
Yes, sir, I'll start it. So, good evening, one and all, for this seminar today. Myself, Dr. Shrutika Surake, coordinating this webinar with Dr. Jagruti Patil. I'm working as an assistant professor in B.R. Harne, Ayurved College and Hospital, Wangi, Thane. I welcome all of you for today's webinar.
त्याला
Please
बोलायचं असून तुम्ही बोलले चांगलं वाटलं
Dr. Shrutika, you are not audible. Dr. Shrutika.
Dr. Shrutika, you are on mute. I think your audio is on mute. Yes.
Am I
now it
audible
is.
now?
Yeah,
Okay.
Yes.
So I welcome all the dignitaries for today's webinar. So before proceeding, I will request Dr. Jagruti to please start with the Dhanvantari Stavan.
Namami Dhanvantari Devam Suray Surair Vandita Pada Padmam Loke Jara Bhaya Mrutyunashanam Dataramisham Vividhaushadhinam शङ्खं चक्रं जलौकां दधतमृतघटं चारुदोर्भिश्चतुर्भिः सूक्ष्मस्वच्छातिरुद्यां शुकपरिविलसन् मौलिमम्भोजनेत्रं कालाम्बोदोज्ज्वलाङ्गं कटितटविलसत् चारुपीताम्बराढ्यं वन्दे धन्वन्तरिं तं निखिलगदवनं प्रौढदावाग्निनीलं प्रौढदावाग्निनीलम्. Shrutika, you are not audible.
Thank you, Dr. Jagruti. So on behalf of Nima Obgy Central, I welcome all the dignitaries and participants for today's webinar, for today's very knowledge-enhancing webinar, I will say. So the topic for today is color Doppler interpretations and its clinical importance in pregnancy. I would first of all like to begin by welcoming Dr. Ashutosh Kulkarni sir, President of Nima Obgy Central, Dr. U.S. Pandey sir, Secretary General of Nima Central, Dr. Shantilal Sharma sir, Treasurer of Nima Central. I extend a warm welcome to Dr. Kamini Dhiman ma'am, President of Nima Obgy Central, Dr. Priyanka Nakade ma'am, Secretary of Nima Obgy Central, Dr. Vishnu Bhavne sir, Treasurer of Nima Obgy Central, Dr. Rajesh Utani sir, Convener of Nima Obgy Central. Also, Dr. Suhas Herlekar sir, President of Nima Obgy Maharashtra, Dr. Manoj Gaikwad sir, Secretary Nima Obgy Maharashtra, Dr. Ajay Raj Bal sir, Treasurer Nima Obgy Maharashtra. So before starting the session, let me give you all a few instructions. Please keep yourself muted. If anyone is found unmuted, he will be kept in the waiting room or removed from this session. So please maintain the decorum of the program. And if you all have any query or questions, please raise your hands or you can mail it in the chat box given. So we will start with explaining our Nima Obgy agenda. Nima Obgy, that is the National Integrated Medical Association Obs and Gynecology. It imparts education in supporting and protecting the character, status, and interest of the integrated medical profession in general practitioners and also practitioners of Obs and Gynac. Our object is to spread knowledge and to widen the education in integrated Obs and Gynecology, including human reproduction, family welfare, contraception, and other allied problems. It is connected to promote services for betterment of the health and community, especially maternal and child health. So with this, let us continue with what we have come up to our 26th webinar series. So as we all know, our topic for today is color Doppler, its interpretations and clinical importance in pregnancy. So all of us, we come into account with the sonographic findings, right? So ultrasound sonography, which we say, and we are always in some doubt that how to interpret the reports, how we should apply it for the betterment of the patient's treatment and advice to give. So here we have our expertise for today, Dr. Kunda Shahane madam. I would request Dr. Jagruti to please introduce Dr. Kunda Shahane ma'am.
Hello, am I audible?
Yes, yes.
Thank you, Dr. Shrutika. Good evening, everyone. I am Dr. Jagruti Patil. Today, we are very lucky to have here with us a distinguished clinician, Dr. Kunda Shahane ma'am. She will guide us through her novel thoughts regarding today's topic. So, we warmly welcome you, ma'am. We are honored to have you with us. It is my pleasure to introduce all of you to Dr. Kunda Shahane ma'am. Dr. Kunda Shahane ma'am completed her fellowship in fetal medicine from VS Medical College, Ahmedabad, Gujarat. She is FMF certified. She completed her PGMS in OBGY from GMC Nagpur. She is the director and consultant at Mayflower Fetal Medicine Center, Dhantoli, Nagpur, and practicing in Nagpur as fetal medicine consultant since 9 years. Her special interests are genetics, fetal therapy, and fetal ultrasound. She is the member of Society of Fetal Medicine in India. Also, she is the founder member of Society of Fetal Medicine in Maharashtra. So I request you, ma'am, to please deliver today's lecture. Thank you so much.
Thank you for such a wonderful introduction, madam. I would like to thank Nima Obgy Society and the organizer team to arrange this webinar and giving me this opportunity to present my topic, that is Doppler in pregnancy. So shall I start?
Yes, ma'am, please.
Yes, ma'am, please.
Okay. Is my screen seen on? Am I audible and my screen is visible there?
Yes, ma'am.
Okay. Thank you so much. Moving towards role of Doppler in obstetrics. I am Dr. Kunda Shahane. I am consultant fetal medicine practicing in Nagpur. I have my own clinic, Mayflower Fetal Medicine Center at Dhantoli. So today's topic is Doppler in obstetrics. So in day-to-day practice, in day-to-day practice, we come across many high-risk patient, or even for the routine patient, we use all the modern techniques. So one of the modern technique is to use the fetal Doppler for the betterment of the patient. So our being a practitioner, all our aim is to make the motherhood safe, and we want safe and normal fetus. Our aim of using Doppler is to diagnose fetal hypoxia, fetal anemia, to diagnose cardiac defects, special non-cardiac obstetrical situations, malformation, and to diagnose fetal aneuploidies for screening in first trimester, to diagnose multifetal pregnancy complications, and differential diagnosis of oligohydramnios. So in day-to-day practice, nowadays, ultrasound examination and color Doppler has become an integral part of modern obstetric care. We'll see the role of Doppler from trimesters, first trimester, second trimester, and the third trimester. So with the help of ultrasound, we see fetal presentation, amniotic fluid volume, cardiac activity, placental position, fetal biometry, fetal and maternal anatomic survey. This is the routine thing that we do on ultrasound at particular gestational age of the fetus. But Doppler has its own role to predict many things, and that we'll see step by step in this presentation. So our vessels of interest in Doppler are uterine artery, umbilical artery, middle cerebral artery, aorta, ductus venosus, renal arteries. These are our interest of arteries to see in Doppler. So we'll evaluate Doppler trimester wise. So role of Doppler in first trimester. As we all know that first trimester is in first trimester we routinely do the NT scan. For it is nowadays it is a universal approach for each and every pregnancy. That pregnancy undergo first trimester NT scan, that is to be done for screening of Downs. So other than these soft markers like nuchal translucency, nasal bone, FMF angle, CRL, ductus venosus and tricuspid regurgitation, these two soft markers are Doppler soft markers. With the help of Doppler, we add this soft marker to get the precise risk of aneuploidy. As we can see that abnormal ductus venosus and tricuspid regurgitation may be associated with trisomy 21. Here we can see that abnormal ductus is associated with trisomy 21 in 83% of cases and tricuspid regurgitation in 67% of cases. So once we do the first trimester scan, it gives us a precise risk when we add multiple soft markers like NT, nasal bone, ductus venosus, tricuspid regurgitation, and FMF angle. So on the basis of evaluation of these soft markers, we get a particular risk, whether this pregnancy is low risk for aneuploidies or high risk for aneuploidies. The most common aneuploidy we are worried is Down syndrome. So once the risk is positive or high risk for Downs, we should counsel the patient regarding diagnostic testing in the form of chorion villus biopsy or amniocentesis. If the risk is negative or low risk, no further screening is required, and we can give her a expectant management. So that was regarding down screening. Now the other role of Doppler in first trimester to diagnose some early anatomical defects. So with the help of Doppler, we can diagnose single umbilical artery. This is a most important soft marker, though it is of minor soft marker, but once we get it in the first trimester, that this is a case of single umbilical artery. So further evaluation is very easy because single umbilical artery may be associated with renal anomalies. It may be related to congenital cardiac heart defects. So at early trimester, at 12 weeks, we know that single umbilical artery as a soft marker present. So we can counsel the patient to undergo fetal echocardiography and targeted scan at around 18 to 20 weeks. So we could find out whether there is associated cardiac defects or whether it is associated renal anomalies, because in some patient it may be present. And if we say to patient that this is a soft marker, we need to rule out in the second trimester, then the patient will definitely do the scan at that particular level. Even we can add the biochemical screening markers to this pregnancy. So we'll get a combined screening and we can give a precise risk to the patient and counsel accordingly. Actually, I have seen many patients where in the first trimester, single umbilical artery is missed. And that patient directly came around 24, 26 weeks for the anomaly scan. And it is found out that it was having a major congenital heart defects. So any clue in the first trimester, it will definitely help your patient's outcome, definitely help in the counseling of the patient. So each and every soft marker that we can see in the early scan, it should be definitely seen. And it should be interpreted also for further management of that case. Okay, then we can diagnose presence or absence of renal arteries in the first trimester. If renal arteries are present, that means bilateral kidneys are present. If renal arteries are absent, that means bilateral kidneys are absent. Even unilateral absence of renal artery may give us a clue that unilateral kidney agenesis may be there. Even early trimester scans, we can rule out the major cardiac defects like single ventricle, complete AVSD, that is complete atrioventricular defect, crux are absent. So when we do TVS NT scanning in the first trimester, we can see even 4-chamber heart, 3 vessels very nicely in the first trimester. Then another soft marker is presence or absence of ductus venosus. Ductus venosus is to be seen in the first trimester as a soft marker also to see the reverse A wave. And also its presence or absence is also important to find out the associated anomalies of heart. So that completes our aneuploidy screening. Then the role of Doppler for early diagnosis of fetal anomalies, which are possible to diagnose. Then the most important thing to see the uterine artery Doppler. Uterine artery Doppler is used as a predictor of preeclampsia, oligohydramnios, and fetal growth restriction. See, this is the prediction. So we are predicting that this pregnancy may develop this type of complications. So at that time, when we predict something very early, we can start management and that will give a better outcome for the pregnancy and healthy baby may be there. So here we can see that in the first trimester, uterine artery Doppler shows us the implantation and the maternal arterial remodeling. Here we can see this is the normal uterine artery Doppler and this is the abnormal uterine artery Doppler. Just on a visual effect, we can see this is normal and this is abnormal. Here we can see the systolic blood flow. The diastolic blood flow is almost 50% of the systolic blood flow. This is systolic and this is diastolic. Once we see the waveform in this form, we are not worried It suggests that it is a normal waveform. Once we see the picture like this, here we can see there is notching, and the diastolic flow is very, very little compared to the systolic flow. So we don't want placentation like this. This is the reflection of uterine artery Doppler and suggests improper placentation. So once we see the waveform like this pregnancy may have the complications like PIPIP, that is preeclampsia, intrauterine death, prematurity, fetal growth restriction, and placental abruption. All these are because of uteroplacental insufficiency and improper placentation. So here we use the negative predictive value of uterine artery Doppler. So negative predictive value of uterine artery Doppler is around 93%, which is much more for our prediction and the management of such patient. With the help of this, we can start early at around 12 weeks to prevent complication in the further gestational age. This is a chart. Here we can see in the first trimester, if the uterine artery PI, here we use the uterine artery PI value, which if it is more than 2.5, which is mean uterine artery PI value, then that pregnancy is at risk of having PI-PIP complication. If we see the second trimester cutoff, it is around 1.75. That is a detrimental value. If it is more than that, the pregnancy is at risk for having the complications related to improper placentation. After seeing this picture, age, body mass index, ethnicity, obstetric history, cigarette smoking, and uterine artery mean PI. Out of all this, we can see here that the likelihood ratio related to age, BMI, ethnicity, obstetric history, it is like this. But once we see uterine artery mean PI, here we can see the likelihood ratio of around 10, which is much more compared to all these parameters to depict that pregnancy is at risk for preeclampsia or not. So definitely, when we do the first trimester scan, we always want to undergo that patient for uterine artery mean PI value, because it helps a lot to prevent many complications in the second and third trimester. So now we have completed the first trimester and the role of Doppler. Now we'll move towards the role of Doppler in the second and third trimester. Mostly in a later gestational age, we use umbilical artery, middle cerebral artery, aorta, and ductus venosus for the management of patient. Our aim is to diagnose fetal hypoxia. So what do you mean by fetal hypoxia? Fetal hypoxia is the oxygen deficiency in the tissues of that may be because of any cause, but that leads to aerobic environment into anaerobic environment and the acid formation. And the oxygen supply, if it is not restored, the fetal death may occur. So with the help of Doppler, we can diagnose 3 types of hypoxias. One is hypoxemic hypoxia. So hypoxemic hypoxia is due to the reduced placental perfusion with maternal blood, and consequently it is reflected in the fetal circulation. The other one is anemic hypoxia, where the fetus himself or herself is suffered from anemia, and because of that reduced arterial blood oxygen content and because of low fetal hemoglobin concentration, there is occurrence of anemic hypoxia. Then the next is ischemic hypoxia. Ischemic hypoxia may be due to reduced blood flow to the fetal tissues due to a local level of obstruction to that particular organ. Most commonly in obstetric cases, Doppler we use for diagnosis of fetal growth restriction and the timing of delivery. Fetal growth restriction, we diagnose fetal hypoxia by detecting the redistribution of fetal blood flow. It helps in deciding the timing of delivery, measuring amniotic fluid index. For neonatologist and obstetrician, till last decade, we have 2 main enemies for the fetus. One is prematurity and the other is fetal hypoxia. But see, with the advent of surfactant and ventilators, we are not more worried about prematurity because we can treat it very well and rescue the babies. So it has changed the thinking process of management, and we are more worried about fetal hypoxia nowadays. We don't want fetal hypoxia to reach at that level that we can not rescue that fetus, and the fetus is already in a sick state. So we cannot manage even with the help of surfactant and ventilators. So being an obstetrician and fetal medicine specialist, our aim is to have that particular balance between the severe hypoxia decompensation phase and the late compensation phase. So in the majority of severely fetal growth restricted fetuses, sequential deterioration of Doppler precedes BPPS deterioration. So Doppler changes in a sequential manner and BPPS deterioration. Here we can see the flow chart. Here we can see that there is reduced growth, then cessation, then reduced amniotic fluid, that is oligohydramnios, and then we can get abnormal FHR pattern or non-reassuring fetal heart rate pattern. This is the cascade of series in fetal growth restriction when we rely only on NST and the BPP, that is biophysical profile, which is very late appearing phenomenon. But below that, once there is reduced growth speed, we can see changes in umbilical artery and middle artery Doppler ratio. We can see abnormal aorta middle cerebral artery Doppler ratio. We can see abnormal ductus venosus very early to happen before this non-reassuring fetal heart pattern. So Doppler is always reliable to have the particular time for management of pregnancy and delivery. So here we can see that the percent of survival gain per week gain. So each and every day that we postpone the delivery in prematurity, when we consider the gestational age of 25 weeks to 32 weeks, even a single day that is postponed for delivery may give a 1 to 2% of survival gain. So if we want to postpone the delivery of that premature fetus, we can take the help of Doppler, and even frequent Doppler studies are helpful to make a charting. And once it is out of like in a late decompensated phase, we give steroids and deliver the baby safely. So our artery of interest is umbilical artery. This is the commonest artery and first artery to study for our Doppler studies. Here we can see the waveform of umbilical artery. Umbilical artery is very easy to sample also. And nowadays we only use PI and RI values and the visual impression of umbilical artery Doppler. We study systolic and diastolic flow of umbilical artery, and on the basis of systolic and diastolic and average values, RI and PI and SD ratios we can calculate, but nowadays we are using RI and PI values for the management purpose. So umbilical artery waveform is always a low impedance circulation. With the increasing gestational age, again the impedance decreases, and with good amount of forward flow in diastole, which increases with the advancing gestation. It is easy to vessel. Interpretation is important. In multifetal pregnancy, we need to sample at the bladder level of each fetus to prevent it from confusion. Then we can delay the delivery till diastolic flow is present. So after even doing a single artery evaluation, we can postpone the delivery till there is some amount of positive flow present in the waveform. Clinical correlation with the maternal factors will always improve the fetomaternal outcome. These are the waveforms. This is normal umbilical artery waveform. Here we can see absent diastolic flow. This is abnormal waveform. Here we can see reversal, and here we can see the typical reversal pattern of diastolic flow. So at this phase, fetus is already in the decompensated phase. So this shows diseases that obliterate small muscular arteries in placental tertiary stem villi results in the progressive decrease in end diastolic flow in the umbilical arterial Doppler waveform until it is absent and then its reversal. So at this time, when there is reversal of diastolic flow, we must consider that more than 70% of placental arterial obliteration is there. On the basis of waveform, here you can see nicely that this is a normal waveform. See, this is systolic, this is diastolic. Diastolic flow is almost 50 to 60% of systolic. This is the normal waveform. And here we can see that umbilical artery PI is 0.97, which is absolutely normal. When we see this waveform, here we can see the systolic blood flow is okay, but diastolic blood flow is very reduced. This much is only blood flow in the diastole. When we see umbilical artery PI, it is showing 1.47, which is too high for the gestational age. It is 32 weeks, 1.47 is too high. When we take a cutoff for Dopplers in umbilical artery, it should be less than 1.2 at least. If it is any Doppler PI, umbilical artery Doppler PI, more than 1.2 is not good. We should keep a watch to such fetuses, and fortnightly or weekly Doppler is advised in such cases to time the delivery. So once we have seen umbilical artery and it is showing an abnormal pattern, then our aim is to find out what other arterial abnormality is there, like multivessel Doppler examination we do. First one is umbilical artery, then second one is middle cerebral artery, third one is aortic isthmus, and the fourth one is ductus venosus. Then we also do for diagnosis of hypoxia and redistribution. For hypoxia, we do the Doppler studies. For CNS evaluation, we do the biophysical profile score on ultrasound. In middle cerebral artery, we see the normal flow or redistribution. This is the normal flow and this is the redistribution. Here we can see increased end diastolic flow. Here we can see a high resistance flow. See, the systolic flow is this, and this is the diastolic flow. In a normal fetus, MCA blood flow should be a high resistance blood flow. Systolic is more, diastolic is low. This is the normal blood flow in fetus. Once we see the changes that increased in diastolic flow, means the fetus is having large diastolic flow, high amount of diastolic flow, which is saying as the central nervous system failing signs. So this is not a good Doppler pattern waveform of middle cerebral artery. And we must take the average of both middle cerebral arteries, right and left, must be calculated for more precise results. So this is the normal waveform of middle cerebral artery, and the PI of middle cerebral artery, here we can see 1.68, and it should not be less than 1.4 or 1.35 at any gestational age. If it is less than that, it is mostly suggesting us a redistribution or low velocity central nervous system circulation of the fetus. Here we can see the systolic and diastolic flow. The diastolic flow is much more, and diastolic flow is much more compared to systolic flow. The waveform should be like this, with PI of around more than 1.4. If it is less than 1.4, then it is showing the signs of redistribution. This is the middle cerebral artery, and bilateral taking at this point, and making the average mean of bilateral MCA to calculate the PI value of MCA. The other important thing after evaluation of umbilical artery and the middle cerebral artery, we calculate cerebroplacental ratio. Cerebroplacental ratio is important to take further decision on the basis of ratio. It is a better predictor of perinatal complications than umbilical artery PI alone. So RI of MCA and umbilical artery, it should be 1. If it is less than 1, then we should plan a delivery of such fetus. See, MCA is a high resistance flow and umbilical artery is a low resistance flow. But what happens in fetal hypoxia? MCA becomes a low resistance flow and umbilical artery becomes the high resistance flow. So what will happen to the ratio? It will be naturally less than 1. And once it is less than 1, it is time to deliver the fetus because it will detrimental to the fetus in utero environment. The next common vessel to study in Doppler is ductus venosus. Ductus venosus reflects volume management by right atrium and it is responsible for the fetal oxygenation. It dilates when there is fetal hypoxia worsens. There is reversal of A wave due to atrial contraction suggestive of cardiac failure. Here we can see this is the A wave, okay, and this A wave gets reversed due to severe fetal hypoxia and the sign of heart failing of fetus. And this is the actually after studying ductus venosus, there is no much time because fetus is already in a failing cardiac failure. We even don't have a time for steroid. If prematurity is there and fetus in the already in the much severely sick fetus, CNS insult already sets in. So ductus venosus is the last vessel to study, and on the basis of ductus venosus, when we find out such a detrimental reversal of A waveform, the fetus is already in a bad state, and rescuing such fetus is very difficult. So before doing ductus venosus, another artery, that is fetal aorta, we can study, and we study aortic isthmus. Aortic isthmus is the part of aorta located between the origin of left subclavian artery and the connection of the ductus arteriosus to the descending aorta. This is the segment we study. This is the aortic isthmus. Here we sample with spectral Doppler and we get a nice waveform. After seeing this Z-score, we can see the pattern of umbilical artery, pattern of aortic isthmus, pattern of ductus venosus, and pattern of MCA. So this is the umbilical artery pattern. We can see a smooth increase in the umbilical artery Doppler studies, high resistance flow. When we see aortic isthmus, this is the point when it's getting deteriorating. When we study ductus venosus, this is the point when it is getting deteriorating. After considering middle cerebral artery, this is the point when there is MCA is deteriorating. So first deterioration we can see in the umbilical artery. Next to that, we can see in middle cerebral artery. See this line. Then we start here, aortic isthmus, then here, ductus venosus. When we see deterioration point of aortic isthmus and the ductus venosus, at least we can have 6 to 7 safe days period to act on. All this thing is only when we do the serial Doppler studies, right? Serial Doppler studies means first study we have done, then we have asked the patient to come after a week or fortnight according to the condition of that fetal Doppler studies. Then we can have the advantage of aortic isthmus Doppler. Once we see that aortic isthmus Doppler is deteriorating, we start steroids to that pregnancy and plan the delivery. So we need not to go till this ductus venosus detrimental effect, because once we diagnose ductus venosus problem, waveform problems, Fetus is already sick with the cardiac failure. To rescue such fetus in the neonatal period is very difficult. So our aim is to find out the balance between these two. So the advantage of this is to give the time to give the steroids. At least say 48 hours we have, that we know on the basis of Doppler. And it is not as difficult as ductus venosus. The ductus venosus, as the most difficult vessel, a smallest vessel is ductus venosus to study. So aortic isthmus definitely we can study, and we can give the take the advantage of that 7 days to act on, give steroids, and then deliver. So being an obstetrician, we have a timeline from the late compensated and decompensated fetus. So with the help of ischemic aorta Doppler study, we get that 7 days safe window period, and we can act on it. So as we all know that giving steroids to a pregnancy prevents decreases the incidence of respiratory distress syndrome, intraventricular hemorrhage, necrotizing enterocolitis by 50% in the preterm fetuses. So it will always benefit our fetus. Now, role of Doppler in special obstetric situations: for diagnosis of fetal anemia, for diagnosis of malformations, commonly cardiac, central nervous system, differential diagnosis of oligoamnios, and the diagnosis of complications of multifetal pregnancy, especially twin-to-twin transfusion syndrome. First, we'll see fetal anemia. The most common causes for fetal anemia is Rh incompatibility or Rh asimilation, then parvovirus B19 infection, and maybe others. So how to diagnose? We diagnose that on ultrasound with the ultrasound signs of hydropic fetus, like ascites, fluid across the fetal cavities, Buddha position, decreased fetal movements, placentomegaly, and much more. But these are very late signs, as only 40% fetal survival once the hydropic changes sets in. This hydropic changes sets in because of congestive cardiac failure of the fetus. But when we consider the treatment before having a fetal hydropic changes, then the fetal survival rate will be around 85%. So our aim is to diagnose fetal anemia prior to happening of hydropic changes. So here is the answer for that: MCA PSV to diagnose fetal anemia. Middle cerebral artery PSV is very important to predict blood viscosity in circulation. Decreases in HB levels causes decrease in viscosity, and we can see increase in blood velocity because of that on MCA. It is a proven method with sensitivity of 98%, and we plot this on a particular interval every fortnightly. We plot on this graph. Here we can see the zone A and zone B on the basis of MOM values, that is multiple of median, means commonly happening particular levels. Once we plot our values, gestational age and the value of velocity, middle cerebral artery peak systolic velocity, once it goes from zone A to zone B, that means the fetus is going from mild anemia to severe anemia. And in that case, we need to transfuse blood to the fetus. If we diagnose with the help of MCA, surely we know that we can rescue the fetus with the help of in utero fetal blood transfusion, and more than 85% effective, and we can save the fetus, compared to less than 40% when we diagnose hydrops fetalis in the fetus and then give blood transfusion. So our aim to rescue such fetuses start in the start period of gestational age, follow it, and once we get a chance and on charting it is showing that there is severe anemia, we should give a blood transfusion. In this video, we can see that this is a fetal in utero blood transfusion. In this patient, we have given 3 blood transfusion started at the gestational age, right from 28 weeks. This is the umbilical vein, and we are transfusing fetal blood. We are transfusing the O negative fresh blood with hematocrit around 80% to this pregnancy. And we have rescued this fetus. Patient was referred with strong ICT positive and with previous baby and with RH incompatibility case. Next one is role of Doppler in fetal echocardiography. As without Doppler, we cannot do fetal echocardiography, as our aim is to diagnose structural as well as functional abnormality in the fetus. So for every aspect of fetal echo, we need to use Doppler spectral and the spectral waveform and all parameters for the Doppler. Then role of Doppler in diabetic pregnancy. Directly, there is no role of Doppler to diagnose as directly for the diabetic pregnancies. But yes, as the mother is having chronic diabetes or type 1 or type 2 diabetes, placental changes may be there, and this can in return may cause hypoxia. So our aim is to diagnose hypoxia. And other than that also, diabetic patient may at risk for preeclampsia, then placental hemorrhages, hyperglycemia causes placentomegaly and increase even fetal weight. So fetus may at risk of hypoxia. So we do it as an indirect benefit to diabetic pregnancies. Then in twins it is definitely important to diagnose the TTTS. And for first trimester, uterine artery Doppler values are not that much specific for twins pregnancy as compared to the singleton pregnancy. But definitely, yes, for TTTS, we have to see the umbilical artery Doppler. Umbilical artery Doppler studies at the level of bladder of each fetus, and we see whether there is decreased umbilical artery Doppler indices. In donor fetus, we can see decreased umbilical artery Doppler these indices, increase RI and PI values, and middle cerebral artery, we can see redistribution, and we can even say decreased cerebroplacental flow, depending upon the severity of TTTS. Then in recipient fetus, the fetus who is accepting the extra blood, which is not needed to that fetus. So here we can see again decreased middle cerebral artery PI values and tricuspid regurgitation due to cardiac failure. So donor fetus is at risk of hypoxia, and the recipient fetus is at risk of congestive cardiac failure primarily. Then another is to diagnose the reason for oligoamnios. Oligoamnios may be because of bilateral renal agenesis. It may be because of uterine artery Doppler that is at fault due to improper placentation, or maybe simply it may be because of leaking. So for that purpose, we need to rule out whether the renal arteries are present, kidneys are present or not. Then uterine artery Doppler we have to undergo. Step by step, we need to rule out each and every etiological factor for oligoamnios. And finally, once it is all good and leaking is there, history of leaking is there, then we depict the case of leaking for oligoamnios. Then the role of Doppler for special situations, like we can diagnose many vascular lesions with the help of Doppler. Here we can see the vein of Galen. Simply, if we do not use the Doppler studies, then we can see only the lesion. It may be a simple cyst, or it may be a Blake pouch cyst, or it may be a interhemispheric cyst. Once we put on the Doppler, we can see this is the vascular structure, and then we depict this as a vein of Galen. So it helps. Then in post-term pregnancy, nowadays we don't allow patient to go post-term, but if sometimes patient comes with the post-term pregnancy overdue than the expected date of delivery, in such cases we have to rule out the hypoxemic hypoxia. And if the Doppler is normal, we are we assure the patient that everything is fine and we can allow her for the waiting period and the trial for normal delivery. Even the role of Doppler is there in the maternal autoimmune diseases. Here, because of maternal autoimmune diseases, we keep a watch start from the early gestational age, monitor the patient for improper placentation, that we have seen that prediction of preeclampsia in the first trimester. We studied the uterine artery Doppler in the first trimester and follow regularly to see even these maternal autoimmune diseases on antibodies can impact or affect the fetal heart also. So our aim is to do fetal echocardiography early at the age of 18 to 20 weeks. And in such fetuses, we need to see frequently. Every month there should be a Doppler and the echocardiography to see the affection of organs of fetus due to these maternal antibodies, because these antibodies transferred from the mother to baby through placenta and may cause hypoxemic hypoxia also and other cardiomyopathy and other organ involvement also. So to summarize, our aim is to take a detailed history of patient. This pregnancy, previous files, previous growth, previous weight of the previous baby's weight, previous scans for the gestational age and growth. If at all we have the growth patterns, then we can study from that also, because all we want to prevent the complication for this pregnancy. Then uterine artery Doppler is important to use in the first and second trimester. We use the negative predictive value. If it is normal, we are assured that this complication may not happen in the pregnancy. If it is present, then we know that we have to start, like we have to start ecosprin in the first trimester. If any other because of autoimmune diseases, it is reflecting like this, we need to give immunoglobulins to patient, we need to give heparin, we need to give much more treatment, start from the first trimester. So we are not delaying any treatment. We predicted and we have started the treatment. It helps a lot for the growth of the baby and good pregnancy outcome in second and third trimester. Then umbilical artery Doppler, which is a common vessel to study in second and third trimester if it is needed. If on the clinical examination we are suspecting any fetus not growing at that level, so we should go for the Doppler studies and growth scan to see whether the growth is proper or not, amniotic fluid is proper or not, whether umbilical artery Doppler is good or not. In some fetuses, it reflects in the form of high resistance flow. Such fetuses, we need to counsel, such pregnancies, we need to counsel that this pregnancy may need a frequent Doppler studies. We need to do charting, and accordingly we need to act on it. Because once we study, we know that what we are doing. Because some patients do a scan, then we counsel them to do the scan in a serial way, but patient don't come and ultimately IUD happen. So our aim is to do a serial scan, because we want to time the delivery. Doing one scan and forgetting it, it is not done. If we are doing any Doppler and suspecting anything in the patient, we should counsel the patient that this is the problem and these are the progressive changes. It is not in the one go. We have to study at the interval basis. We have done now, then indices we need to study after 15 days. We have to put it on the chart pattern. If it is showing that these are the progressive changes and deteriorating, then we need to give steroids at the proper time and deliver the baby. We need to balance, because one finding is not sufficient to deliver the baby. We don't want to hurry that the Doppler changes are there and we want to deliver it now. It should not happen, because umbilical artery shows that the high resistance flow has started. It is not detrimental right now. It is a compensatory phase of fetal Doppler. So once we give the report, it should be clear that after how many days we need to do a Doppler, what will be the next proceeding, and we have to do the further management, like when to give the steroids and all, because we have already seen from the flow chart that each single day postponing the delivery helps the fetus a lot. It increases fetal survival by 1%. This is much more for the survival of the fetus. Then middle cerebral artery is another additional artery that we study, and it suggests us the brain sparing effect, that is cerebroplacental ratio and fetal anemia. For fetal anemia, it is a wonder artery that we study, and on the basis of that, we can give fetal blood transfusion very early before the start of fetal hydrops in fetus, and we can rescue such fetus. After giving fetal blood transfusion, the fetal anemia resolves, and it gives a magical effect, and we can see that after delivery even. Then aortic ischemic Doppler will be more useful in obstetric practice, because it gives us a time to react, to give steroid instillation. Traditionally, we do umbilical artery, middle cerebral artery, and ductus venosus. But nowadays, we do umbilical artery Doppler, middle cerebral artery Doppler, then aortic isthmus, and then ductus venosus. Because studying ductus venosus and finding out like absent or reversal of A wave, the fetus is already sick, and that fetus, after delivering in a prematurity, will not give a healthy fetus. Even neonatals, good neonatal setup, the babies are not that much with a good survivability. So doing isthmus Doppler at the proper time, giving steroids and delivering baby will help a baby in a lot manner. So Doppler improves the perinatal and probably maternal outcome in high risk group of patients, and that is what as an obstetrician we always want. So there should be no hesitation by doing scans, and even third trimester third trimester ultrasound should be associated with Doppler values, so we can predict. In some patients, obviously on a clinical examination, we cannot see many things, but once we do a Doppler at around 34 to 35 weeks and see the Doppler values, sometimes we can pick such high risk cases and reassure them accordingly, or deliver them early before happening of IUDs, intrauterine death. Sometimes we see also 9 months intrauterine fetal deaths. So a Doppler may solve our problems to diagnose such cases in the third trimester. Thank you. And here we can see this bridge, which is the bridge of modern appliances or modern technologies that we can use for making a pregnant ladies to the healthy outcome of her pregnancy. So we'll discuss 1 to 2 cases. Here, a lady with 34 weeks of pregnancy with having preeclampsia, pregnancy-induced hypertension. Her BP was just borderline 140/86 in the first time. Then no warning signs, no proteinuria, blood test okay, preeclampsia profile is okay. Fetal well-being scan was done, and it was suggestive of fetal growth restriction and lag of around 3 weeks in abdominal circumference. AFI shows 7 centimeters. So one factor is fetal growth restriction. The other factor is oligoamnios. And Doppler study we have done, it was showing umbilical artery PI is 1.6 with decreased diastolic flow. So definitely it is alarming sign that growth restriction is there. Doppler studies are not good. Then the second step of evaluation, we can see here that middle cerebral artery is normal. There is no redistribution, and the CP ratio is 1.1. CP ratio less than 1 is detrimental. Any CP ratio 1 or more than 1 is okay, and we can have some days to deliver the fetus. Then aortic isthmus and ductus venosus Doppler normal. So in such cases, how should we go further? So this is a okay finding. Patient is okay. 34 weeks of pregnancy, Doppler values are good. So we can go forward in such cases. We can ask the patient to come every week. Weekly Doppler studies are to be done, then plotted on the chart. And once we see CP ratio less than 1.1 or redistribution in the middle cerebral artery, then we can plan a delivery. And even we are not worried because the pregnancy is around 34 weeks, so almost near to maturity. So it is very easy to take a decision in such cases. The next case is a lady with, this is the second gravida. Here we can see the live zero, G2P1 live zero. First baby is not there. Previous history of IUD at 37 weeks of gestation. This is important. Now this pregnancy, she is 28 weeks with fetal growth restriction with normal amniotic fluid. But we know that she is having a history of live zero, IUD at 37 weeks. This is very important history. Now at this point, she is again having fetal growth restriction. Now we have done a Doppler study. So Doppler study, what it suggests? It suggests umbilical artery PI 1.4 with decreased diastolic flow. So again, umbilical artery Doppler is not good and other rest vessels will be normal. So how should we go further in such cases? So pregnancy is around 28 weeks, fetal growth restriction, amniotic fluid is okay, and umbilical artery shows just little bit increased resistance. So we called the patient after 15 days. So in such cases, we must call the patient fortnightly. So 15 days we called again. Now we have seen again umbilical artery Doppler PI. So previously it was 1.4, now it is 1.6. So it is progressively increasing with maintained CP ratio, cerebroplacental ratio, and normal rest vessels Doppler. So at this point, again, we are not worried that we know it is normal CP ratio. Okay, so we are not panicking in any situation. Again, we'll follow after 15 days fortnightly. Then at 32 weeks, again, we have plotted everything on a chart, okay, progressive way of deterioration. Then 32 weeks, positive flow with redistribution with CP ratio less than 1. This is alarming now because 32 weeks, minimal flow as good as absent diastolic, redistribution and middle cerebral artery with decrease less than 1 CP ratio. So at this point, the gestational age is around 32. Now again, at this point, dilemma may be there because Doppler is very bad. Gestational age is 32 weeks and previous history of IUD. So we need to think, study, and then plan the management of such patient. So 32 weeks is prematurity only. So we need to think about steroid also. Then we must go for aortic isthmus Doppler. We have done it. It was normal. Ductus venosus also normal. So we given her a steroids, 2 shots of steroids, waited, and then after completing 2 doses of steroids, we delivered. So we prevented many complications of prematurity with the help of steroids. We postponed the pregnancy till 32 weeks with the help of this modern technique, Doppler. We plotted on the chart and everything documented related to the compensated phase, decompensated phase, action, and the delivery. So this is the proper management we should go for. Any clue we are getting in the first trimester, second trimester, third trimester, interpretation is always important because without interpretation, we cannot plan management for that particular patient. And definitely it helps a lot to make a safe mother and safe motherhood. So with this note, I would like to thank you and thank you for patient hearing. Hope you all understood this topic. Thank you.
Thank you so much. Hello.
Questions are welcome. So any questions, any doubt related to Doppler studies, any cases we can discuss?
Ma'am, I have raised few questions in the chat box. Please group.
1 minute, let me see.
First of all, thank you very much, ma'am, for delivering such a nice lecture.
Yes, the question is, please elaborate role of amnio infusion in severe oligoamnios. Yes, in severe oligoamnios, first thing is to evaluate the etiological factor of oligoamnios. Once we ruled out everything, the most common cause is bilateral kidney agenesis. If it is ruled out that there is no bilateral kidney agenesis, the second factor is hypoxia, hypoxemic hypoxia. So hypoxemic hypoxia is because of the maternal improper placentation, maternal reason, which is reflecting in the form of oligoamnios. And in such cases, we may have a role of amnio infusion. We generally, in such cases, we do the Doppler studies. On Doppler studies, if we see the normal, these Doppler, fetal Doppler studies in the form of umbilical middle cerebral artery, then we give fetal amnio infusion, and it should be almost 15 to 21 days. We need to repeat it, because whatever amnio infusion we are doing in an artificial way is resolved after some days. But definitely it gives a window for the growth of fetus and even lung maturity of the fetus. So definitely there is a role of amnio infusion after ruling out everything as a etiological factor for oligoamnios. Then the next question is Doppler useful to identify small for gestational age and IUGR babies? Small for gestational age, actually we defined it, small for gestational age is not a problem, because if the mother father weight is small, the fetus may have a small weight, estimated fetal weight. But when we plot at an interval growth, we can see a progressive growth, but the growth is below that percentile. But there is definitely a growth that is small for gestational age. But in IUGR fetuses, the baby has its genetic growth potential should be at that level, but baby is not growing with that genetic potential. So any abdominal circumference less than 10 percentile is suggestive of fetal growth restriction. So in small for gestational age, Doppler may be normal, but in fetal growth restriction, Doppler shows a progressive changes, and we need to plot on this at a particular time. Then next is what is the usefulness in screening fetal well-being, NST and biophysical profile? So NST and biophysical profile are to see the CNS status of the fetus, and Doppler changes are far earlier when we study in a serial way manner. BPP and NST, these are non-reassuring fetal heart patterns that we see afterwards once there is CNS insult. So NST and BPP are useful as a part of fetal monitoring in the later gestational age, but definitely when we suspect anything as a fetal growth restriction, we must go for the serial Doppler studies. Betamethasone is the good steroid to give. Then role of magnesium sulfate in prematurity and doses. There is a role of magnesium sulfate in prematurity, but we can give it but I am not in more favor to give magnesium sulfate because doses need to be calculated in a very precise manner and complications may there. So video, can we assure the same lung maturity in SGA baby as of normal full term? Same lung maturity in SGA baby as of normal full term fetus. Yes, in small for gestational age, there is a normal growth and development as a genetic potential of that baby. What is brain sparing effect and how it can we evaluate the brain sparing seen in nearby 32. So that we, by given steroids, we can wait or plan for daily. So if we see brain sparing effect means middle cerebral artery, the second step of evaluation showing a redistribution. So we calculate RI values of MCA, RI values of umbilical artery, and when it is the ratio is less than 1, it gives us an alarm to take the action. But now today I have done a Doppler, okay, and it is showing a brain sparing effect. So what should I do? I should see aortic isthmus Doppler and the ductus venosus. Now I have done ductus venosus and aortic isthmus Doppler. Both are normal. So I know that I have 7 more safe days. So I can give steroids, 2 doses complete, and then deliver the baby. But definitely we need to deliver the baby within the 7 days span because we have that 7 days safe window period. We should act on that.
Okay, thank you so much, ma'am. The next question is, in the color Doppler report, which should be more relevant, means SD ratio or RI or PI?
SD
And
ratio
what is
should
the
not
reason
be used
behind it?
nowadays because it is very confusing and the values are almost confusing for everybody. So nowadays we only rely on RI and PI values, and most of the time PI values of umbilical artery. SD ratio was previously very much used, but nowadays it is RI and PI values of Doppler.
Thank you, ma'am. In IUGR, if SD ratio of umbilical artery is normal, can we delay the delivery till term? And what the limit we take decision to terminate the pregnancy?
Can you repeat the question, please?
In ratio umbilical artery is normal, can we delay the delivery till term, and what limit we can take decision to terminate the pregnancy?
Okay, see, commonly we do fetal Doppler scan. In a low risk cases we are discussing. Okay, in the 3rd trimester, we go for the Doppler studies or growth scan and Doppler studies around 34 to 35 weeks. Okay, so at 34, 35 weeks, when we see that everything is normal, Doppler indices are okay, DPP is okay, growth is all okay, amniotic fluid is all okay, then we can give the chance to go till term. We should not go beyond term, but we should go till term. It will be a normal expectant management in a low risk case.
Thank you, ma'am. If there is RH incompatibility in mother, at initial level, when should we do the MSA PSV?
Yes, yes. So in RH incompatibility, RH incompatibility mostly happens in the second or successive pregnancies. First pregnancy is always rescued, as rather first pregnancy is a sensitizing event for that. So once we have a history of RH negative pregnancy or RH incompatibility, what patient comes to us with the ICT positive report, or patient comes to us with the history of 4 to 5 in utero death like this. So we know that this is a RH incompatibility case. Okay, after evaluating previously, now the patient is having pregnancy. So first trimester, we are not worried because fetal reticuloendothelial system is not developed to recognize by the mother, and the maternal antibodies don't affect fetus. Okay, it is the 16 weeks onward or second trimester where reticuloendothelial endothelial fetal RBCs start developing, recognized by the mother as a foreign body, and maternal antibodies coming and affect the fetal RBCs. So from 16 weeks onwards, we counsel the patient that every fortnightly, that is every 15 days, we must go for middle cerebral artery. We plot a chart in the MOM values, and accordingly, once that zone changes after plotting, we give blood transfusion because we want to prevent fetal hydrops to happen.
Okay, thank you so much, ma'am. I think you have clear our all doubts. So this is the end of the question and answer series. Now, on the behalf of Nima Obgy Society Central and Nima Obgy Society Maharashtra body, I would like to express my gratitude to Nima Central Dr. Ashutosh Kulkarni sir, Dr. U.S. Pandey sir, Dr. Shantilal Sharma sir, for the remarkable support. I extend my gratitude to our Nima Obgy Central President, Dr. Kamini Dhiman ma'am, Secretary Dr. Priyanka Nakde ma'am, Treasurer Dr. Vishnu Bhavne sir, and Convener Dr. Rajesh Utane sir for supporting and guiding us to conduct today's webinar. I would also like to thank and extend my gratitude to our eminent speaker, Dr. Funda Shahane ma'am, who took time from her busy schedule and delivered very knowledgeable and wonderful session. I would further like to extend my gratitude to our Nima Obgy Maharashtra President, Dr. Suhas Irlekar sir, Secretary Dr. Manoj Gaikwad sir, Treasurer Dr. Ajay Raj Bal sir for their support to conduct today's webinar. I would also like to thank Dr. Girish Daga sir, Dr. Arpita Shah ma'am for the help and technical support. And last but not the least, I would like to thank from the bottom of my heart to all the delegates for their participation and presence. Without them, this webinar would not have been possible and succeeded. Now, with the due permission of all the dignitaries, I am concluding today's webinar. Thank you for all attending and hope you have learned and gained great knowledge from today's speaker. Thank you so much.
It is all my pleasure. Thank you so much. And good night to all. Thank you. Shall I leave the session now?
Yes. Thank you so much.
Thank you, ma'am.
Thank you. Thank you. Thank you. Thank you so much.
Thank you, ma'am.
Thank you. Bye-bye.